So while he's sharing a screen, I just want to welcome everyone today. My name's Laura Goldberg. I work at Hospitals of Cleveland, Rainbow Babies and Children's. I'm a pediatric sports medicine specialist, and I'm super happy to present Dr. Neeru Jayanthi today. He is Emory's tennis medicine program director and really considered one of the leading experts on youth sports health, injuries, and sports training patterns. As well, he's an international leading in tennis medicine. So he's currently president of the International Society of Tennis Medicine and Science, certified as a teaching professional, has been a volunteer in multiple different tennis groups, and he has been selected to the board of directors for the AMSSM twice, serves as a consultant to the AAP, American Academy of Pediatrics, Council on Sports Medicine and Fitness, an Aspen Institute Sport and Society program, and on the MOMS team. So Dr. Jayanthi has won multiple AMSSM Foundation research grants for his collaborative research on sports specialization, training, and overuse injury in young athletes. He was previously the medical director at Loyola University for 12 years and voted top doctor in the suburbs of Chicago prior to being recruited to Emory, where he is now. He is just an amazing lecturer. He's been a course director millions of times, talked lots of times, and we're just super happy to have him here to talk about overuse injuries in our youth athletes. As we go through this, please make sure to put into the chat any questions you have, and we can add them in as necessary. Also, this fellowship online lectureship is really driven by you. If there are ideas or thoughts that you have about topics, please let us know. You can email by the end of the talk, I'll put up a QR code for where you can kind of find that, or you can go to the AMSSM website and find the QR code there where you can put in topics and ideas of speakers. And we really want your input, so it is directed towards you. So without further ado, here is Dr. Jayanthi.
Awesome. Thank you so much, Laura. Laura and I share a passion for youth sports and kids who play sports, but I think all of us as sports medicine doctors should. I recertified my CAQ last year, barely got in. I almost missed the deadline to get signed up, but I begged them because I said I'm a fellowship director at Emory, and my fellows will be really upset if I can't do that still, or maybe they'll be happy. And then I studied it. I'm no joke. I opened the big board review book and I flipped to a page. I'm not joking. And I literally picked to a page. I did a question. It was a question, and the reference was me. And then I'm not even sure if I got the question right. Like I went back, I'm like, is this what they were asking? So I get it. It's not that easy to take boards exam. So I think the first half is kind of board type, like it's very objective stuff that's been clearly published that I believe would be some of the stuff that you get. And we have some questions at the end on that. The second half is actually, I think it's important. You guys are all folks who are going to be interested in taking care of youth athletes and be experts in it, I hope. And so kind of what we're doing, moving forward. And so you're a step ahead of the game. So anyway, thanks again. And, I help run a youth sports medicine program. I run our Emory Sports Medicine Fellowship. We love everyone. There's no specialty we don't take. Of course, I like people who like young athletes, but that's not the only thing. You do not have to play tennis to come to our fellowship, despite what these pictures might say. And so I do a ton in you name an organization. I try to be involved. It especially helps young people. My current newest task is being the chair of the USA Sports Science Committee, which is just starting and has actually been a lot of fun, but a lot of administrative work as well too, to try to make a difference. Changing culture and changing sports takes a lot of work, and I hope some of you guys will. We partner with our Emory Sports Performance Research Center by Dr. Greg Meyer, and he does some of the most groundbreaking injury prevention work like this. That's a joke. That's just a great video, but we do partner with the Falcons with this. But his bulk of his work in that research institute is on youth sport injury prevention. If you have a moment, if I can make a plug, we very much believe in education. We make our conferences free for any learner. It's always been I run a lot of these meetings, and I just think you should just educate. That's our role. So if you wanna, it's a virtual hybrid meeting. We actually create a template for abstract submissions, case and research, and it's right at the end of ACSM, which is on the So it's on Saturday and ACSM ends on Friday. So if you have some great stuff, we'd love to hear from. I think it makes it better when you guys who are doing great stuff during your fellowship or maybe med school or wherever it is, need a platform to have a really good audience. I think AMSSM is the awesome platform, but sometimes maybe it's big and you want to talk to a group of, like 100 people or whatever it is, and, have a little more interaction. That might be good. So, I've said this before about youth sport. We don't want to be sports injury doctors. We need to be sports medicine doctors. And so that first goal is to look at ways that we're increasing physical activity, increasing youth sport participation, and improve performance. That's really our goal. The treating an injury should really be a part of it. I know that's how we make our ends meet and we see patients in clinic, but I hope you're doing things outside of clinic to impact the other areas. And you're an advocate for those things and advocate for environments where kids can play sports. And that includes every time I coach all my kids who are in, you name a league we're involved in, and have a voice for safety, for inclusiveness, for every kid to play. And your guys are powerful voices, so use it. And so we want these kids to play sports for a long time. Unfortunately, some of them get sidelined by youth sports. This was a few years ago, and myself and a couple other doctors were featured on some of our research on youth sports and some of the detriments of it. So I think it was probably the third smartest doctor on this, with Min Coker from Harvard and Neera Pandya from UCSF, but I might have the best hair out of the group. That's just my thought. But this is our goals for this talk are, I always say, youth sports. How do I keep playing? I mean, we want to recognize those overuse injuries. We also want to recognize either a serious and high risk overuse injury. And it's actually a really important thing, especially, these don't come across enough sometimes. And, for maybe someone like Dr. Goldberg, who is seeing pediatric sports all day long, she may encounter a lot more, but some practices are, you see a kid every now and then, and you just can't afford to miss the high risk overuse or serious overuse injuries. And we want to make sure we recognize those. And then, this whole issue of sports specialization, I want to get into a little bit more and actually where are we going forward with this? Because it's not just about sports specialization. These are my kids when they were much younger, but we should recognize the injury risk factors, which we recently published on, and also where burnout, nutrition, and other things may play a role as far as training. So this position statement, myself and a number of other really great people were part of it. Gosh, I think we did this originally about, I want to say almost 15 years ago. Then we did a revision, and actually it was actually really good. We didn't write a new one. We just kind of approved this version of it. It's actually, and it added a couple of small sections. At that time, our risk factors were intrinsic, extrinsic. You see training load, prior injury, specialization, and age. We've evolved. We actually have more specific ones we just published in Sports Health we'll go over. But what we did recognize, and this is fairly consistent across several studies and even our current studies, that it's about 50% of injuries reporting to, and they're biased by their clinics like ours, primary care sports clinics, they're overuse. So about half of injuries tend to be overuse. And if you had to look at the profile now of what an at-risk athlete is, take an adolescent female who's going through peak height velocity, who does an individual technical sport, who specializes at a young age, trains more hours per week than their age, and 16 or more hours, does not play sports for fun, family has money, trains more than 8 months a year, and has prior injury and may have some psychological stressors or other. So I always say this kid is one injury away from quitting sport, one injury away. And so it's just what's going to push him over the edge. So we have to be very careful. I saw a 9-year-old gymnast today, and the usual, like level 5, 20 hours a week, and she has hip impingement. And what do you do with it? What do you do with a 9-year-old with hip impingement? Like, this should be a college discussion. And so I think we have to be mindful of where we're introducing things. And so the decision is really up to families and coaches, but who stays in sport, it's fairly clear right now. The kids who don't quit are usually boys versus girls. They're older, they're diversified, and they are involved in injury prevention programs, and they have good quality life. And then the ones that don't have poor physical literacy, and they are adolescent age ranges, and they have a poor support team. We've published on the positives and negatives. You can actually specialize and have a positive support team and do well, but a poor support team is focused on winning and having negative interactions following competition and other things, and training environment, of course. So so we look at this issue with sports specialization, and this is not a sports specialization talk. It's hard not to talk about it a little bit, given our environment today. But this is where I thank AMSSM incessantly, because when we started this process of researching it, we wanted to do something big. We partnered with Cynthia Labelli at Lurie Children's, and we said we need to get a large sample, and we couldn't do it without funding. Where do you go for sports medicine funding? Like you need $20,000 or something like that to really do a nice study, even get the ball rolling. And thank God AMSSM actually funded this study twice. And this really catapulted this whole publication process of, at least for our pathway on sports specialization. We recruited about 1,200 athletes, and it took, gosh, 3 years to recruit and follow, and 5 years overall. It was a very large sample, and things that you probably know, but I think now it's really nice to see. It's showing up in CAQ board exams. It's showing up in mainstream. I'm so proud of the work of all these folks that help contribute to these findings, which is overuse and serious overuse injury increases, not acute, but those increase with more hours per week than your age. So if you're 16 or 15 years old and you do 16 or more hours, it's a higher risk. If you did more year-round training, more than 8 months a year, and the 2-to-1 sports training ratio is that's the number of hours per week of your organized sport over your free play. So it's basically if you play for fun, like 5 hours a week, and you train, 12 hours a week, that's 12 over 5. So it's over 2. And those were adjusting for all their factors were highly significant. And in fact, when you talk about serious overuse injuries, which we define as having 1 month or longer prescribed by the physician, it was even a stronger correlation. So it was the largest, we believe, and still I think the largest clinical case control study on sports specialization and training patterns. And it'd be very hard to reproduce. I hope someone could and does, but it's just very hard to reproduce because it just took a long time to recruit. And so we defined serious overuse injury. We decided to do that because people get patellofemoral pain. I think 25% of our most common injury, I think, was like 23% was patellofemoral pain. And it may not alarm people to do it, to have that, but actually bone stress injury, OCD lesions, UCLs, and other things that keep you out for longer do alarm people. And these overuse injuries, can be really dangerous. And so that's not quite overuse, but we did need to define, what sports specialization is. And I just came back from ACSM team physician consensus statement meeting in Arizona, and we had to put that on paper. And David Bell and that group in Wisconsin has actually published a reliable, they did a whole Delphi consensus statement on it, but still the operational definition is this. And I asked them, I said, do we use yours? They're like, no, that's not your operational research definition. So it's basically these 3 components of choosing a main sport, quitting all of their sports to focus on one sport, and then year-round training or competition more than 8 months a year. And so, if you have all 3, you're highly specialized. If you have 2, you're moderately specialized. If you have 0, 1, you're lowly specialized. And so,
And then
can you guys
are a great way to.
Can you guys hear this okay? Andy, sounds okay? Someone tell me yes. I'll play
Yes,
until
we can hear it.
Great, thank you. And then this summarizes, actually, this was in in our local news out here, but I really like the small clip. It summarizes it pretty well.
Kids physically active.
I've played pretty much every single sport besides volleyball.
I've played soccer and done ballet. No, I played all the sport.
But
Could
more
be
than
my
a third
son,
of injuries in kids are sports related. Researchers from Emory University looked at data from 1,200 young athletes over a 3-year period. They found that for kids under 12,
those that specialized were more likely, about 1.5 times more likely to report an injury.
when they start specializing too young,
You have to acknowledge that the risk of injury and burnout is just higher.
the study also found that kids are playing more organized sports, twice as much as they're playing for fun, which can lead to overuse injuries. So what can parents do? Delay sports specialization until their child is 12. Also,
Encourage more seasonal participation. Maybe have a 3-month period where they're either taking off and resting.
another thing is making sure your young athlete is training fewer hours per week than their age.
If you're like 14 years old, train less than 14 hours per week.
Proper warm-ups and cool downs are critical.
Especially as they get older and matches and everything's a little more intense, a little more physical. it's important to make sure your body can like keep up with that.
But the most important thing is just to have fun. I'm Marty Salt reporting.
All right. Yeah, my son, that was the beginning of my son's acting career. Now he's like got agents and he's 12 and he actually gets auditions all the time. I like to say that we started with this a little bit there, but so now we take these training recommendations and we want the kids to learn them and understand them. Those are probably the most common ones. The data is pretty strong. It's actually been reproduced by a number of investigators, and I point to the Wisconsin group because they've done a number of longitudinal studies as well too, and you probably have all read those as well. But so they, I think they're solid enough to be in boards exams and also for your own clinical practice. But we want to do an intervention, see, can we actually help kids follow these recommendations using maybe our data, NATA, and the AMSSM position statement. And so and I won't go through all of it, but we get our training load history on every young athlete. And then we calculate certain things about their workload, their acute to chronic workload ratio, their sports training ratio. And then we know that if you exceed these things, you're at risk. So we wanted to see if we could do a randomization study a number of years ago to see if we could reduce their risk of injury through serial training. And actually over the course of like a year, you could see the top row injury rate without intervention. The bottom row showed a lower rate of injury throughout the entire study period, which is great, but we didn't see a difference in compliance, which now we're doing a new study I'll go over. But the specific areas that we saw the strongest one was this free play issue. And I think culturally, and Dr. Goldberg is around for a while, maybe a few others, but this is what we see in our neighborhoods. The kids all play for fun. And actually free play is probably protective of overuse injury. And so that's been one of the things, and that's one of the areas where they're less compliant with. And then also there's a strong association with if you train less than 16 hours a week. For some reason, not only just train your hours per age, but 16 itself seems to be a magical number of where you really, Caroline Emery had this old data where it would just exponentially increase your injury rate. So maybe because you get to 3 hours a day, I'm not sure, but that's been other investigators even before we started our work on there. And so, we believe that these modifications may reduce injury. Now, we want to try to improve compliance, and we've learned, I don't know if you guys know this, but kids watch videos. And so we felt we want to come from a positive aspect and we want to give healthy sport recommendations. And now there's more data. There's sleep and nutrition and other areas. And so now we have a crossover randomization study of giving videos, basically YouTube short type videos that are kind of tailored to your gender and stage of development. And I think Haruki, our old fellow, our chief fellow, he's on here. Ali Render is on here, who helped with these studies, and Anna Buser, and we've had our research group is. So let's see if this one shows up. This is one of the videos.
Next, we're going to talk about healthy sport recommendation for physical activity and strength. It's important to get 60 minutes of exercise every day. This can include your sport practice or can include a variety of other types of physical activity. It's also important each week to get at least 2 days of strength training. This can be body weight exercises or a supervised strength program. What do you like to do for physical activity?
I like to ride my bike and swim.
Oh, those are great options. What do you like to do for strength?
I like to do squats or planks a couple of times a week. And then we fight.
Okay, yeah, of course, my actor kid always has to find a way to make it a joke. But and actually, we have preliminary data. I think we submitted this, sorry, Haruki did, to AMSSM for this cycle. But it's pretty cool to watch these kids be compliant with watching videos, and we're hoping to see if that'll improve their actual behavior patterns. So we'll find out as we collect our data. I think we have like 200 enrolled, so we'll find out. So we published a paper in Sports Health looking at, so we can talk all we want that we want to have people stop specializing and play multiple sports, but the reality is it's going to take another 10, 20 years, I don't know, to change that culture, or maybe never. So we have to be able to work with the kids who are training intensely. And so we published in Sports Health a few years ago about methods to do that. And that would specifically be looking at these areas and looking at workloads, looking at biomechanical deficits, addressing those, changing things based on your stage of development, and also training load progressions. And And so what we do is we try to evaluate the risk, and our traditional model is to look at workload, how much they specialize, their developmental phase, and then gender actually, and females versus males. So Stacy Schley, who now everyone's an attendee now. I keep calling them my fellows, but Stacy is at Boston Children's, and she helped really drive this awesome study that was just published in Sports Health a few months ago, looking at a star risk assessment, basically kind of a little mile to the left of what we do for REDS or REDS, and try to give a point system. And it's actually somewhat predictive to determine who might be most at risk for overuse injury. And so it's really using a lot of these principles that we just talked about, including the stage of development, and then determining what their future risk of having an overuse injury is. Ann Abuser, who also just graduated, she's doing a family medicine residency, who was in those videos you just saw, also just published in Sport Health on sex differences in overuse injuries. And it's not good news, unfortunately, for the female youth athlete. Most of our findings drive towards the young female athlete in overuse injuries. And it's interesting, they train more months per year and they do less free play than male athletes, which is a bad combination based on what we knew before. They obviously enter pubertal stages earlier, so they may be allowed to kind of hike up their volume a little bit earlier, but we have to be very mindful. And I think that's a future study, an area of what is not the vulnerability just with what we know about ACL injury risk and that area, but I think there's a vulnerability with female athletes with overuse injury, and it's not good to have all these risks when we need to encourage young female athletes to continue to play. So a concept, and I don't know if any of you guys have heard of biobanding, but we try to group kids based on their pubertal stage, and so roughly up to 85% based on this new concept of PPAH, which is percent of predicted adult height, we'll say they're either pre-pubertal or they're going through the second phase of peak height velocity, and the third phase is when they get skeletally mature. And we think maybe this middle phase is when they're really vulnerable for certain types of growth-related injuries, and we might have to alter training patterns during that time. And that's what they do in other countries like the UK. We're effectively doing electronic biobanding with our study because we give recommendations based on stage of development. And go to your own kids or friends' kids' practices. Nobody alters things based on stage of development in America. Almost nobody. So we have a big opportunity to change that. We do all the same things with the same kids and group everything based on age. And you have to recognize there's kids going through different things. Here's adolescent awkwardness. If you look at their kid in the back there, that's blue. That's Andy Meyer, who had set up this call when he was like 11 or 12 years old. So your mom shared that for me, Andy. So thank you. Tell her thanks. So there are lots of areas when you look at a kid, again, like Dr. Goldberg probably seeing kids all day long, so she's always thinking of these things. But I can tell you there are a lot of sports doctors who are not regularly seeing them. So you got to look at, when you look at an elbow, there is no such thing as a tennis elbow. You have to think of the growth plate and the apophysis and other areas. And if this is, if we think of the shoulder, there is no rotator cuff tear. And this is, you have to think of the proximal humeral physes, and the low back is not an adult disc problem. It is, we have bone stress in that area, and even an apophyseal problem in the hip joint we're seeing more, but apophyseal problems, I actually don't take too lightly either. I think they have morbidity and they affect performance, and even though they're not as high risk. So now we'll look at these high risk injuries, high risk overuse injuries. And Lori, keep me posted if there are any questions, or you yourself want to ask or slow and stop me down.
Yes, I'm keeping track.
Okay, got it. So again, I think when we wrote this position statement for AMSSM a number of years ago, we felt it was important for all clinical providers to understand when to worry, really. We just don't want to lose sight of these ones that really make it different. So we had to define it. We thought this is different than the serious overuse injuries. These had more morbidity, and we thought these that could result from significant time away and perhaps even need surgery. So they really were more significant. So if you miss them, bad things could happen. And I call it I don't know, I don't hate to call it the dummy rule. I tell my fellows that you never want to take care of something, have a disaster, send them over to your surgeon and say, I'm so sorry I missed that. And they kind of like, oh man, what happened with that sports doctor? Why didn't they even recognize that? So you just want to know it's okay to manage high risk injuries if you're aware of it as it's going on. But I would be careful. I've been doing this for almost, 20, 23, 24 years, and I'm very careful with the high risk ones. And I'll go over some of those, okay? Because they have a risk for potential for surgery. And if you get surgery late and they're non-union, it's bad. So we actually called low risk ones that didn't have that same significance, but I believe they could still be serious. Like you could have overuse injuries that keep you out for over a month, you may not need to have surgery. So when we think about these things, you got to think about the type of athlete who gets them. So all the risk factors that we talked about are the ones who are the ones who may get serious or high risk overuse injuries. It's not very common for a seasonal athlete, multi-sport, who only trains 3 months a year and has low training volumes and all these other things. They don't really get most of these things. So that's where, but we're talking about the elite level, and they're the ones who get it. So there's a few categories that we put them in the stress fractures, but there's high risk stress fractures, FICs, OCDs, and then we decided to include effort-induced thrombosis, and this is pretty rare. But so we'll start with a simple clinical case scenario: a 13-year-old with axial low back pain during soccer, obviously probably in his peak height velocity. So we think of high risk locations. We'll go with central back, which is the low back, anterior hip and groin, which of course we can consider the femoral neck, anterior knee, patella, but specifically patella when we're talking about bone stress, anterior leg, not just leg, anterior leg. So that's anterior tibial cortex. Foot and ankle needs its own slide because there's so many high risk areas, but medial midfoot, which is the navicular area, the medial ankle, medial malleolus is a high risk area and not a common area for bone stress but fracture itself. Lateral foot is really lateral midfoot, which is base of the fifth metatarsal, and plantar great toe is sesamoid problems we'll talk about briefly. So for every high risk area, there's probably a low risk area. So when you have a high risk tension-sided femoral neck stress fracture, technically it's low risk. I still think this is not low risk, but I was outvoted by the committee. I think, even a compression-sided femoral neck is important to me, but it has less of a propensity to need surgery, and you can probably treat it non-operatively in the right treatment algorithm. And same thing with pedicle stress. I think it's low risk, but it's less likely to have a fracture line. But I've had pedicle, and I don't know about you, Laura, but I still get pedicle fractures from bone stress injuries in the back, and so I'm not so sure it's as low risk, but the PARS is obviously the high risk here. And anterior tibial cortex.
I'll tell you, I mean,
Yeah,
I think those pedicle stress fractures are more annoying than the PARS.
right.
They seem to linger longer and they're harder to calm down.
Yeah. Totally. I mean, can you believe this, Laura? Laura and I could probably talk forever about these things. I had 4 or 5 doubles players, all high level, between 12 and 13 years old. Both doubles, the teammates, both of them had bone stress injuries in the back. And I had like 5 doubles teams going at the same time. And there was 2 girls, some of the top girls in the area, who had gapping. I mean, and they had an MRI, and I was like, oh, this isn't that bad as a pedicle. And then I got a CT, and they had gapping, fracture lines that took 8-9 months. And they were so compliant, I couldn't believe it. And they actually came across and healed later, but that's why my heart dropped. I was like, so I'm with you on that. I was like, but anyway, this was the consensus at the time that maybe they're not as high risk, but thank you for supporting that. So we'll go over specifically. I have some slides on all the Taylor stress injuries that they can have, and in the foot. I think I've set slides for those areas. But the fibula obviously is lower risk, and in the knee, OCDs, and we have a picture of that as well too. But the patella, which is a rare area, is a significant area for bone stress. It just has a propensity to fracture, and then and OCDs in the elbow, of course, and then distal radial widening is one of the few areas where you can get growth arrest and stress injuries, and of course, gymnasts we worry about with that. So, I call it a game of inches. And so you could have a tension-sided medial or superior, perhaps compression-sided. Maybe it will do okay most of the time. But, I think at this stage, I can say I'm comfortably enough to probably manage without talking to anyone. If you're early on, your first few years in your practice, I would probably pass these by and make sure that your surgical colleagues are comfortable with it so you don't send them something that didn't do well. If you've managed anterior tubular cortex enough times, and I don't know if anyone can say they're a big expert, but I feel like I'm comfortable enough to talk to a patient about managing it conservatively. This is the dreaded back line that you don't want to see, but you can try. It's long. I use bone stimulators on every single one of them, and it's a very long process. But you should have an excellent relationship with your surgical colleagues so that, again, you don't want to hand them a non-union and put a rod in there because you did not discuss that enough. But that is an important area. So when you palpate the anterior tibial cortex, not just the posterior medial area. It's a different area, and always look at your lateral. Tarsal navicular, I've had several of these, and I'm telling you, even ones that like I thought were, I'm like, it's not. I went and got it. They have, they had a bone stress injury, and even from the first day, I'm like, oh, there's no way you're this sore. You haven't done enough, and they were. And then we've had ones that were late. That's the end spot, we call it, the mid portion of the navicular. This area on the kind of most medial side is where the posterior tib tendon attaches. You get an accessory navicular. It's not high risk, but I pay attention to that end spot, and then a little bit less over the medial side. We're okay. Here's the base of the fifth metatarsal. Again, when I was at Loyola, gosh, I mean, it seemed like every basketball player would come in and transfer and get a bone stress injury. And you're stuck when you're an athlete. You can't wait 3 months and see if it gets done. You have to fix some of these. And so you have to be very careful with them. The talus, again, here's the lateral. When you see bone stress in the talar neck, that can be potentially high risk. And again, would deserve, I think, a healthy discussion with your surgical colleagues. If you're going to choose to treat it non-operatively, at least give them a heads up in case it doesn't go well. Sesamoid, oh my gosh, I see a fair amount of sesamoid issues because I treat a lot of tennis players. And here is a bipartite sesamoid. And can anyone tell, even when you get an MRI, is that bone stress, AVN, or a fracture? And I don't think so. I've talked to enough radiologists and they're like, I don't know, I can't tell. It just looks like edema. So, I actually think this one right here is not just, this is bipartite. It looks like there's some AVN type appearance there, but it's very hard to tell. So I pay attention to sesamoids in higher level athletes, a lot. So in the natural history is not favorable. So just pay attention to plantar to great toe pain. And Laura, any personal experiences, data, anything, jump in and tell me, because this is what I feel is my experiences.
I don't have data, but I have a patient today that's 14 weeks out from jamming her toe, but she's a dancer. And it's a medial, or what we call a tibial sesamoid. There's edema on the MRI, and she has been non-weight bearing 6 weeks. I cannot get her to calm down. And
Yeah.
I guess you guys can't see my arrow, but it is right where your red line is.
Yeah.
Just frustrating.
Yeah, and we looked at the natural history because it's like 6 months, Laura. Like we looked up what is the outcomes of sesamoid bones. It's not encouraging, and so not that that's reassuring, but yeah. So you just throw everything in. Your bone stimulators, reduced load, but yes,
I said that to the parent today. I was like, "This is not abnormal. It's okay. She's not crazy."
Yes,
Frustrating.
yes, they're tough. So the best way to treat higher risk overuse injuries is get them early. We're not going to change this environment. I don't think there's anything me or Laura, anyone else can do. But all I ask is that you have a way to facilitate early intervention. So like I had a kid with probably a symptomatic bipartite, but he's like a week and a half in, and I feel like I'm like, okay, I think we can turn this around quickly. But when you get them late and they're already deep bone edema, they have a fracture line, it's tough. In all these areas that we're describing, it's very tough. That's all we ask. Try to get them early. And that's why I say, I really don't know with these sesamoid things. So OCDs of the capitellum. Whenever you get an osteochondral lesion, all you do is pray they have a wide open growth plate. This one's nearly closed. If they're nearly closed, if there's any sign of instability, see a surgeon. If they're closed, see a surgeon. If they are wide open and you're comfortable, see you. If you're not comfortable, which again, if you're early on, make sure you're talking to your surgeon. In my experience, OCDs in the knee, I can maybe get improved in 3 months. In the elbow, 6 months if we're successful, if we're fortunate. They're not all, their outcomes are poor with that. in my experience. And then in the knees, they're actually not very encouraging either, but the rates of healing are slow at like 6 months, 12 months to 18 months for OCDs. And even at the end of 18 months, you may be looking at 65, 70% healing rates. So just kind of build that into your, kind of decision tree as you're looking at their stage of maturation. Because if they're nearly closed, I like to have them talk to a surgeon because I don't want to lose that opportunity if they were going to do something. This is not the place to talk about bone stress and everything, and this is very rudimentary stuff. We should be looking at energy balance a lot more. I mean, and probably Laura, there should be a red S talk, but there has to be a clear cessation of sport for high risk injuries, and even low risk injuries. I think need some significant modification. So again, these are the areas we talked about. I didn't talk about effort, TOS and effort induced thrombosis as much. That is a whole talk of itself. Robbie Bowers, one of my colleagues at Emory, loves that stuff, so I won't step on his toes. This is a radial physeal stress fracture. I have one story. I should have put that slide in there. I had a girl. Washington Post came down to interview us about some overuse injuries, and I said, oh, I had all these training guidelines, and then I had a young gymnast who I was supposed to have included talk about the success story of following these recommendations, and then she actually had just a radiophyseal stress injury the day we were doing the photo shoot. So I had to put her in a short arm cast. And so she's in the photo shoot with a short arm cast talking about how great my treatment is to prevent overuse injuries. So I'm not that good. And that was when I was researching like 1,200 of them. And I still couldn't, keep her up because it's gymnastics and, you go right back to that environment. We call proximal humeral physeal injuries lower risk. I do agree that it's incredibly rare. I've never had anyone go into surgery or growth arrest. I don't know if you have had, Laura, but I do think they take 8 to 12 weeks in baseball, and we are able to trim it down a little bit in tennis because you can do other things. But again, I'm not, I call them serious overuse injuries, but not necessarily high risk injuries. Laura, have you had any bad complications with the proximal humeral physeal injury?
No.
Yeah.
No, I think shutting them down, they generally do very well. It's just getting them to shut down.
Right. Yeah. So my rule with it, I say, look, the data is that, it's 50% are successful at 8 weeks in baseball. 95% are successful at 12 weeks. So whatever you decide to do, you better not take longer than 12 weeks because you got in early and then you just shut it off again. And we can't be sitting here 4 to 6 months into it because you just didn't want to shut it down. So that's
I tell them, don't throw a wiffle ball to a 1-year-old. Don't do anything.
Yeah, there you go.
Except for bat. And
yeah, bat and field and then toss the ball. In tennis, we actually let him hit. But I go on court with him. That's a whole separate world. And so the general rule with OCD lesions in the knee and probably anywhere is, like we said, if they're unstable, and we're not even sure, is this developmental? Is it overuse training? Is it both? I think it's probably both, but we know that OCDs can happen on its own. And I'm sorry, and osteochondritis dissecans in particular, it comes down to stability and stage of development. So like we talked about, so if you're stable, if your open physes is stable, then you probably will have good results. And like I said,
so before you go on,
yes, go ahead.
just a question about how, like when I see an x-ray and I see a lesion that is probably a osteochondral lesion, I guess my question is the difference between OCD and osteochondritis dissecans. I think of osteochondritis dissecans as likely a non-traumatic developmental problem with endochondral ossification. We don't know, but
Right.
versus calling it an OCD that we see in adults post-traumatically. But how do you know that it's stable or not stable?
Fluid around the rim. And then for me,
As you get an MRI, right?
yeah, I get an, yeah, to back it up, if I can see on the x-ray, again, whether it's right or wrong, I get an MRI at the front end, and I usually get an MRI at 1 year, even if they're back and everything, because I want to see continued stability, evolution of the OCD or the lesion, whatever it is. But yes, I do get an MRI.
So I was just kind of trying to make a list of the things you just talked about and what you would get imaging on. So for an OCD, osteochondritis dissecans in a youth, I would get a quick MRI.
Yes.
Like epiphysitis in the shoulder or the wrist. I would not get an MRI
Never.
right away, but I would
Yeah.
follow that if they're not improving. And
Yeah,
then a
right.
spondy, I don't always get an MRI right away because we treat them, conservatively. And then if they're getting better, great. If they don't, then I get one. How do you feel about that?
So that's a great question, and maybe I'm biased by a bit of my audience because I get a lot of these quote unquote higher level year-round training, like, so I get the information because maybe I'm too intricate with it, but I really like to know their stage of development, their risk. So I get an MRI, we do a 3T MRI, we do like sequencing we look for fracture line using what we call vibe sequences, and then we get the MRI. And then I like to know if it's pedicle or pars, if there's a fracture line or not, if it's unilateral or bilateral. And then I know it seems really stupid and nuanced, but it helps me decide, like we're talking weeks, I know, but like for some of these people, it matters. And so the time frame matters. It helps me outline their potential risk. So if I have a unilateral pedicle and they're later in stage of development, I'm way more flexible with it. If it's a, bilateral and there's fracture lines and their peak height velocity, then I'm going to be way slower. So I don't know if that's right or not. And we add vibe sequences because then now we can actually see fracture line on the MRI with this way we sequence it. But that in my
Part of
every 5 years
medicine.
I change it. Every 5 years I change this just changed it again. So this is
It's
where I'm
art,
at.
art of medicine. It's not it's
Yes.
not a perfect science.
Yes, no, absolutely. And then especially with bone stress injuries in the back, there's like 50 ways to do it. So recalcitrant apophysis, and I just look at fragmentation. This is another thing. I do get x-rays, and I like parents and family to see, like, hey, look, if you have a fragmentation or you're developing ossicle, some of this is not reversible, and it may be if you're earlier on. And while there's not a large percentage, maybe 5-10% that need to get that ossicle removed, those of us see this a lot, see those, and it impacts your performance. So I'm pretty like involved with even, I don't like to, just osgood slider, just take a few weeks off and go play. Like we really monitor them a little bit. And I always say maybe I'm the wrong person to see because we research and follow these so closely. Maybe you should see somebody else who doesn't care as much about like every little thing. But I don't know. I just I don't like not so good outcomes. So this is just the same message again, and I'm preaching the choir probably with a lot of folks on here, is that we just have to make sure that, and this also goes with all due respect to some awesome sports therapists, but make sure your therapists are also familiar with these conditions, and you just have to make sure that the rehab protocols for low back stress injuries almost diametrically the opposite of an adult athlete. And so for every shoulder condition and elbow, everything you have, it's just the opposite for a young athlete. And I just can't reiterate that enough. And that includes your rehab programs for it. And we've talked about these specific areas we want to stay. So we talked about bi-banding. I'm going to kind of move through this. So I want to make sure we also maybe do a couple of cases and a couple of things we're doing. This is the paper that we talked about as changing your stage of development. I'm changing your training based on stage of development. We're looking into our data. We're about to publish with Ben Sachs, is my current fellow. I'm not sure if he joined, but he hears this all the time. Is looking at this distal to proximal thought process of earlier in stage of development. If you look to the left, is earlier stage development, you get things in the heel, like Sever's disease. And as you get farther along, this is in a non-clinical study of youth soccer players in Europe. And as you get farther along, you kind of move up to the leg, to the knee, then to the pelvis. And then, so that kind of corresponds with your stage of development. Fascinating. It's like, these are cluster plots. Then all your muscle injuries and ligament injuries happen predominantly, not all, predominantly in your kind of mid-late or skeletal maturity. And so this is about 80 kids. We have about 450 data points we're going to have. And so we're meeting with our statisticians, and our preliminary analysis actually shows that I think we're somewhere in that area as well too. So it's pretty fascinating stuff. And then, this is our data, but we're going to have new data, so I don't want to show any of that. So just the summary slides for how we treat kids in stages of development. We want to make sure kids who are pre-adolescent are focusing on fun, training less hours per week than their age, playing sports for fun. And these are the common apophyseal issues they may get. In our data set, we don't see very many serious overuse injuries. There's actually a thought with Sean Cummings, a remarkable researcher in in the UK, who feels that the young kids actually can do better by we want them to run around and play, because once they get to peak height velocity, they start having more trouble. So we actually want to encourage, and especially free play. It's like, get out and do stuff. It's okay. We don't see as many bad things. That's our data, and hopefully we're not too off with that. Adolescent athletes, we start to see worse things, apophyseal issues, and then we start seeing people who specialize, and we have to accept that that's a possibility. But they develop really poor neuromuscular control, and I think the only way around is strength. And so we want to focus on strength and coordination and balance with their training, and not as much rapid directional change. So if we can get training changes during this peak height velocity, we might maybe build a better base before they go into post PHV, where we start seeing, it's really fascinating, Laura. I can't wait to show someone like you, like our data set. Like, we see low back stress injuries. There's a cluster between 94 and 98% of adult height. And so we'll find out when we actually pull out all our data. But these are the kind of things that we're seeing in the post PHV, which actually have the most serious overuse injuries, but that's very likely related to training loads and volumes. I'm going to kind of move on. So I'll go actually to, I want to make sure we have time for the questions. I have a couple of cases, but I think it's best we do questions and actually get questions from the audience.
Why don't you go ahead and do your questions, and then if anyone has any questions, please put them in the chat, or of course, feel free to like raise your hand and ask them directly.
Okay. And I'll just do the last thing for those of I have a few people who've spent time with me in clinic. Just our process when we see people is we actually get a PPAH with pertinent information. It's a research formula. It's good. It's not perfect, but it's good at predicting stage of development. Then we just evaluate their likelihood of injury with our STAR questions, our training load questions. And then of course we see them, of course, and then treat them. And then we prescribe our treatment plan based a bit on their risk. Like, if they're high risk, we're obviously have to be more careful. If they're low risk, we're more lenient with how we progress them. And so it's kind of like family medicine pediatrics. That's why I say that's, I spend a lot of time really talking about anticipatory guidance. We're like, hey, you may have about 6 more months in this peak height velocity, and I think you have to be a little careful with this type of injury before you ramp up again. And so there's a lot of that, which I think families really appreciate, for those of us who are brave enough to make less money talking to kids all day long. Right, Laura? Can't stick needles in them all day long. So, but it's so rewarding. The families love it, and they want to be a part of that. So, so I'm going to go right to questions here. I think this is the first one. You know what? Actually, this is a great time to call on someone. I'm going to call in. Is Joe Chrisman still on? I saw him on there. I haven't seen him in a while.
I'm here.
Yay, Joe. All right. Joe, you get to read the first one. I might give you a cupcake here.
I'd love to. All right. From the AMSSM position statement on overuse injury and burnout in youth sports, overuse injury is described as injuries that occur due to repetitive submaximal loading of the musculoskeletal system when rest is not adequate for adaptation to take place. What is the closest estimate of overall incidence of overuse injuries in youth sports?
All right. And then Joe, we should ask Joe before he sees, but all right, Joe, what was your answer?
I put C.
All right. Yeah, it seems like about 50% is kind of the running number for incidents, and the ranges have been around 45 to 54%. So good. All right. Next, who's another brave soul?
The main components in defining youth sports specialization include all of the following except A, athlete identifying one sport as his or her main sport. B, quitting all other sports to focus on one main sport. C, training, competing in a single sport 8 months per year. I bet that's supposed to be more than 8 months
Yes.
per year.
Yeah.
Exceeding the threshold of maximum hours a week of training per age. So remember, when you read these questions, I hate these, but this is an accept one.
So we have A and D were our two biggest ones. And then, so which one is not considered part of sports specialization definition? And it's actually D. So, and I can tell you the historical part of it is when we originally put together the definition of sports specialization, we felt it was gonna be hard to evaluate training load and separate it as a risk factor, because you have to account for it. Because even if you didn't specialize much, but if you trained a ton, then the training load volume would override the actual specialization. So we kept it separate. And when we did our data, we always adjusted for training load, and then specialization risks were still there. So we removed it, not that it's not a risk factor, but then we want to make specialization stand alone. So yes, it was. So it does not include training load as a risk factor for sports specialization.
Just to be clear, it's a risk factor, but it's not
Okay.
on the position statement.
It's not as part of the definition of sports specialization, but it is a risk factor, a separate risk factor. We want to keep it separate. Exactly. All right, we can do 2 more questions.
All right. In regards to pediatric overuse injuries, the specific location of the injury can be classified as high risk or low risk overuse injuries. High risk injuries can result in increased time away from participation in sport and can include stress fractures, physeal stress injuries, osteochondritis dissecans, and apophyseal injuries. All of the following are considered high risk locations except proximal fifth metatarsal bone stress injury. I actually don't know how to pronounce it. Is it Island?
Island.
It's Island's, right? Yep, Island's disease. Pars interarticularis bone stress injury, navicular bone stress injury, and patella bone stress injury.
Okay, yeah, so most everyone chose B, and that is the correct answer. And the best way to remember it, I don't know about you, Laura, is that it's usually vertical. That apophysis is usually vertical. So one way, if you're looking at fracture or stress fracture or anything like that too.
Island's apophysis is parallel to the length of the fifth metatarsal versus the fracture would be perpendicular.
Perfect. Exactly. Sorry, I don't think I had a picture of that. So, all right, last one. Who's the bravest soul?
I can be brave. Justin Chu here, University of
All right.
Louisville.
Hey,
A variety of specific intrinsic and extrinsic factors have been identified that may place young athletes at increased risk of having overuse injuries with sports participation. All of the following are risk factors for such except A, high degree of youth sports specialization, B, female, C, competing in primarily one individual sport, D, participating in sport for more hours of a week than athlete's age, or E, team sport participation.
wow, 100%. Now, 1% thought me. Yes, that is true. Yeah, we had a sport type paper, and we really think actually sport, hopefully it goes back here. Sorry. Sport type actually plays a role. And maybe that's why there's a female predominance of it. And they tend to do more individual technical sports, but it seems like it's playing a role in team sports versus individual sports. So that's adjusted right there. So awesome. Well, I think that allows you guys to understand training youth athletes, biologic maturation, and that kids need to play for fun. And then you work as a team, and things work out just dandy, right?
So, Neeru, thank you so much. I have a couple of comments.
Yes.
One is, first of all, gender is so important, or sex, in the sense that, we know that female athletes, the dropout rate in high school is higher than in boys. And I think what you pointed out is that, these athletes are one injury away from quitting sports, and girls tend to mature sooner than boys, and they tend to have their injuries, overuse injuries, maybe earlier, just because of the timing of when they're going through their maturation. But I think it's very important for us to take away from this about where they are in their peak height velocity, and really be proactive about maybe not minimizing these overuse injuries as much as don't say, oh, just go ahead and go and play. If it doesn't hurt you, go play. Make them realize that there are issues with them. Specifically, I would say in the hip. One of the things that I think with the growth plate injuries that we see a lot of problems with is the hip flexor injuries, the iliac crest apophyses, that really get people to be out for a while. And just, making sure that these athletes understand that it is part of where they are in their development, and we can get them back to being great, but they need to be patient. And I think that, you know, we're talking to a population that doesn't have much patience, and we need to really help them be patient with the healing process. And I love that you say don't specialize before, you know, 12 years old. I think it's really, really important that people play and have fun and go out there and do stuff. And I guess after that sort of diatribe, like, how do you answer patients and families when they say, what do you mean I shouldn't play one sport a year? If I don't play volleyball, club volleyball all year round, I'm not going to make the team. If I don't play softball or baseball or soccer or basketball, you name it, I'm sure tennis is the same way. What is your answer to that? How do I not specialize and still be good at what I do?
Well, you know, and I'll keep this very brief because we should all go, but my brief answer is that number one, I don't judge. And I think it's really important as providers not to judge. And I actually share with them their experience with my own kids, but I'm focused on performance and long-term performance. So I have a higher level athlete. I say, what do you want to do that's best for your child to perform their best? And then I outline what that looks like. And that's actually why we wrote that paper. If you choose to specialize, you may end up at the same place, but you might have a few more risks. And that includes quitting. And I can tell you one thing, and I tell them this with my own kids, my biggest fear isn't that they're not going to be the best player in their league or on the team, is that they're going to quit. And so if you're okay with that risk and the risk of some injuries and you want to try it, that's fine, but you have to surround yourself with a lot of resources. And there isn't any data right now. We have a systematic review in BJSM, and there isn't any data that doing it early gets you to be a better athlete later. If you want to be the best 12-year-old or 14-year-old, it works. It actually, there is data that support that to early specialization improves early outcomes. So the people who want to listen. I don't judge, actually. I have plenty of young specializers, 10, 11. I mean, it's the average age in tennis and youth soccer, actually. So I don't judge. I just make sure that if you choose to do that path, we need to surround ourselves with a bunch of resources. That's why we do all these studies and we give them educational information, and we spend forever in the room. So they just please come in early, recognize early.
I love that.
We're not perfect, but really let's not judge. If you create a dichotomy between you as a provider, a healthcare provider, they're like, they don't want to come see you. And I think maybe my kids are comfortable with seeing me because I'm the one. I'm like, hey, I got to get out here too because I'm playing a 15 over national event. I want to compete. Like I'm with you, but let's, we'll do this together. So, but anyway, it's so good to have you on here, Laura, because I love your perspective and all of you that joined and my research people and former people at Emory, and hope some of you guys can join us for our future meetings as well.
So before we end real quickly, I wanted, to apologize. I did not have these slides up before, but remember the primary goal of this lecture series is to assist in the CAQ preparation. So please scan this. If you want to have some ideas for us, please send them in. We want your input. There's also online at the AMSSM.org education. And then we don't need those because it's afterwards. Also, remember, next week we have Jeopardy style peds, MSK radiology cases. We have Jonathan Smet coming in to talk to us. Be 8:30 as usual on a Wednesday night, and we really look forward to people joining us. Thank you.
Bye, everyone. Thank you. Thanks, Laura. Thanks, Andy.